Imagine facing a persistent infection after shoulder replacement surgery. It's a surgeon's nightmare, isn't it? And a patient's ongoing struggle.
Absolutely.
But one treatment approach, this two-stage revision with antibiotic spacers, it's shown really remarkable success rates. I mean, as high as 95% in getting that infection under control.
That's right. The control rates can be very good.
Yet, as often happens in complex surgery, getting rid of the infection, that's really only part of the story. Does it restore function? What are the costs, the complications?
Exactly. Function is key.
And that's what this deep dive is all about, unpacking that complexity. Welcome to the Deep Dive, the show where we take your sources, the latest research papers, essential articles, even your own detailed notes, and extract the most important nuggets of knowledge or insight. Think of it as your shortcut to being truly well-informed on a critical topic. Today, we're diving deep into a significant research paper focusing on treating infected shoulder prostheses using precisely that two-stage revision approach. And who better to guide us through this material than one of the authors of the paper itself? We're joined today by Professor Mo Imam, an orthopedic expert with an extensive publication record. He brings, well, unparalleled insight directly from the source. It's brilliant to have you here.
Thank you. It's a pleasure to be here and discuss the work.
Great. Let's jump straight in then with a rapid-fire setup to frame our conversation. First question. Shoulder periprosthetic joint infection, PJI. Why is this particular type of infection often considered, well, more challenging to treat than PJIs in, say, the knee or hip?
Yes, that's a critical starting point. Shoulder PJI, it really does present some unique difficulties. A major factor is the microbiology. So alongside more common organisms like Coagulus-negative Staphylococcus, we frequently encounter Propionibacterium acnes, or P. acnes as it's often called now, Cutibacterium acnes.
Oh, right.
Now, while it's often less virulent than, say, Staphylococcus aureus, which you see more often in knee and hip PJIs, P. acnes can be notoriously subtle in its presentation. Sometimes pain is the primary or even the only symptom.
The only symptom, that must make diagnosis quite elusive.
It does. You can't always rely on those classic signs of infection.
Okay.
And then, both P. acnes and other organisms, they readily form biofilms on the implant surface. This protective layer, it sort of shields the bacteria from antibiotics, making them incredibly persistent, difficult to eradicate without surgery, and crucially, local antibiotic delivery.
Subtle presentation and stubborn biofilms, understood. Okay, second rapid question. The paper focuses on a two-stage revision using antibiotic spacers. In brief, what does that process actually entail?
Well, it's essentially a sequence. It's designed to eradicate the infection before reimplanting a new prosthesis. So stage one involves removing the infected implant completely, meticulously cleaning out all the infected tissue, that's the debridement, and then inserting a temporary cement spacer.
A spacer.
Yes, and this spacer acts as a local depot. It elutes high concentrations of antibiotics directly into the infected site. And of course, systemic antibiotics are given as well.
And stage two, what happens then?
Stage two is performed once we believe the infection is cleared and the patient has completed their course of antibiotics. It involves removing that temporary spacer and then implanting a new definitive prosthesis. The goal really is to put a sterile implant into what is now, hopefully, a sterile environment.
Two distinct stages then, aimed at clearing the infection first.
Right. Final rapid-fire question. What was the single most important finding from this specific research regarding the control of the infection itself? I'd say the headline result from this particular series is the high rate of infection control we achieved with this two-stage approach. We saw successful eradication in 36 out of the 38 patients available for the final analysis.
36 out of 38.
Which translates to an impressive 95% success rate based on the defined criteria we used.
95% infection control, that's a really powerful statistic. But how do you get there? And what's the full picture beyond just eradicating the bug? Let's dive deeper into the process, the challenges, and importantly, the patient outcomes in this core segment.
Let's do that.
So diving deeper into that challenge you mentioned earlier, the source material makes it quite clear that shoulder PJI is, well, it's feared by surgeons.
It is, yes.
You highlighted the common organisms found in this study. Coagulase-negative Staphylococcus, that was 42%, and P. acnes at 33%.
That's correct.
And that point about P. acnes being less virulent, but often causing only pain for clinicians listening, that sounds like a crucial diagnostic trap to avoid, doesn't it?
Absolutely. It really is. You simply cannot wait for the typical signs of sepsis or acute inflammation sometimes. Persistent, unexplained pain in a prosthetic shoulder must raise suspicion for a low-grade infection, particularly P. acnes.
Right.
And then, as we discussed, the biofilm protects these bacteria, making surgical intervention almost always necessary for eradication. You can't just rely on antibiotics alone, usually.
And the two-stage strategy is built specifically to address that biofilm and the persistent infection. Tell us a bit more about stage one as it was actually performed in the study. You removed the prosthesis, did the debridement, and implanted that handmade cement spacer loaded with gentamicin and vancomycin. What was the post-operative antibiotic regimen like?
Okay, so the protocol involved 2 weeks of intravenous antibiotic therapy initially. This was often adjusted based on the culture results once the specific organism was identified.
Tailored therapy.
Yes, and this IV course was followed by a pretty substantial course of oral antibiotics, typically lasting for 10 weeks. So the combination approach, local delivery from the spacer, and a prolonged systemic course.
10 weeks oral after 2 weeks for? That's quite a commitment for the patient.
It is indeed. Compliance is obviously key.
Then stage two, the reimplantation. The paper notes that reverse total shoulder arthroplasty, RTSA, was the default for most patients, 26 cases, I think?
That's right, 26.
But hemiarthroplasty, HA, was used as a sort of salvage option for severe glenoid bone loss in a smaller number, 8 cases.
Right.
And quite significantly, 14 patients didn't actually proceed to stage 2 at all. They retained the spacer permanently. Why was that?
Well, the decision for the definitive implant, or indeed whether to implant one at all, was dictated by several factors. Things like the extent of bone loss, particularly on the glenoid side, which can be severely compromised after infection, and the spacer implantation itself.
Right, the socket side.
Exactly. And also the patient's overall medical fitness, or sometimes their willingness or lack thereof for further major surgery. RTSA generally offers better function in many scenarios, but it simply isn't possible without adequate bone stock to support it.
So HA and retaining the spacer were fallback options for the most difficult situations or less fit patients.
Essentially, yes. HA for severe bone loss where RTSA wasn't feasible, and retaining the spacer for those unable or unwilling to undergo the second stage.
And the study population itself, 48 patients treated initially, 38 available for analysis at a minimum of 24 months follow-up. It's mentioned that 40 of the 48 were referrals from elsewhere for PJI treatment. That tells us something, doesn't it? These were likely already complex, established infections.
Indeed. That's a very important point. These were challenging cases, often patients who had undergone previous surgeries. They weren't typically primary PJIs presenting early and otherwise healthy patients. They were often tertiary referrals.
Which makes the 95% infection control rate perhaps even more impressive.
Well, it certainly highlights the effectiveness of the approach in a difficult cohort.
How did you rigorously define and confirm infection control in this study? What was the diagnostic process involved?
Okay, so infection control was defined by the absence of the recognized musculoskeletal infection society, the MSIS criteria for PJI at the final follow-up point.
The standard criteria.
Yes. And the diagnosis itself relied heavily on careful microbiological workup during the surgeries. This involved taking multiple tissue samples. We stipulated a minimum of 3, and culturing them on different media, both anaerobic and aerobic, and crucially, incubating them for at least 10 days.
Ah, the 10-day incubation period again. That seems like a really vital nugget of information for anyone in a lab or clinic dealing with suspected shoulder PJI, doesn't it? Especially for P. acnes.
It is absolutely critical. We can't stress that enough. Shorter incubation times, say the standard 5 or 7 days, risk missing these low-growing organisms like P. acnes.
And if you miss it?
If you don't identify the pathogen, you can't target the antibiotic therapy effectively. It compromises your chances of eradication. So yes, extended culture time is non-negotiable for a thorough diagnosis in this specific setting.
Makes perfect sense. And as you mentioned, despite all these careful steps, the headline result was 95% infection control in 36 out of 38 patients analyzed. Remarkable success for such a difficult problem. What happened in the 2 cases where control wasn't ultimately achieved?
Yes, it's important to look at the failures, too. In one case, it was a persistent P. acnes infection after the reimplantation stage. This was in an older patient with a history of steroid use, which can be a risk factor.
Okay.
The other failure was a persistent coagulase-negative staphylococcus infection, also after reimplantation. In both instances, the patients experienced ongoing pain, but unfortunately declined further surgical intervention.
Right, and that's another factor, isn't it, in managing these complex cases, patient choice and their tolerance for surgical risk, especially after multiple procedures.
Precisely. High success rate, but not absolutely guaranteed, and patient factors certainly play a significant role in the final outcome.
Okay, so infection control is paramount. and the results look good there. But functional recovery is often the patient's main priority, isn't it? How did the study actually measure how well patients' shoulders were working and feeling after all this treatment?
We use standard, validated scoring systems, primarily the constant Murley score and also the relative constant score, which adjusts for age and gender, making comparisons a bit fairer.
Okay.
We also use the subjective shoulder value SSV, where the patient rates their shoulder function themselves on a percentage scale from 0 to 100. And of course, the pain score, which is part of the constant assessment.
And when were these measured?
These were measured before the first stage, so baseline pre-treatment, and then again at the latest follow-up point. That was either after the second stage reimplantation or, for those who didn't have a second stage, after the spacer implantation when follow-up concluded.
Right. Looking at all patients treated with spacers, regardless of the final step, what did the overall group's functional outcomes show? Was there improvement?
Yes, for the entire cohort treated with the spacer protocol. So lumping everyone together initially, there was this statistically significant improvement in the overall constant scores, the relative constant scores, the subjective shoulder value, and importantly, in their pain scores compared to their pretreatment levels.
So, as a group, the treatment did improve symptoms and function overall.
Correct. On average, patients felt better and functioned better than before the treatment started.
Okay, overall improvement is good news. But this is where, as you say, the devil is often in the detail. What did the functional outcomes look like when you broke them down by the type of final treatment? So comparing the RTSA group versus the hemiarthroplasty group versus those who just retained the spacer. This is where it gets really interesting, I think.
Indeed it is. This is where we saw quite marked differences. Patients who completed the full stage process and received a reverse total shoulder arthroplasty, the RTSA, in the second stage showed a significant functional improvement. Their mean constant scores increased notably, from about 31 pre-op to 51 post-op.
A definite jump there.
Yes. However, those patients who received a hemiarthroplasty in the second stage, and also those who permanently retained the cement spacer, did not show statistically significant improvement in their constant and Murley scores.
No significant improvement in those two groups.
That's right. For the HA group, the mean score went from about 22 to 24, basically unchanged. For the spacer group, it went from 18 up to 35, which sounds like an increase, but the p-value was 0.093, so it didn't meet the threshold for statistical significance in our analysis.
Wow. That functional disparity between the RTSA group and the others is really quite stark. Does this finding mean that RTSA is inherently functionally superior for these PJI cases? Or perhaps that HA or just retaining the spacer are simply poor options for function after infection?
That's a really crucial point of interpretation, and one the authors, including myself, discussed at length. The functional difference wasn't necessarily simply due to the type of implant itself. The significant factor was almost certainly the baseline condition of the patient and their shoulder. Patients who ended up receiving an HA typically had severe glenoid bone loss, as we discussed. That necessitated using it as a salvage option. Their potential for functional recovery was already limited from the very start, regardless of the implant.
Because the foundation wasn't there.
Precisely. Similarly, patients who retained the spacer often did so because of significant medical comorbidities or being deemed unfit or inoperable for a second stage. Again, this selects for a group with lower baseline functional potential and perhaps lower demands.
I see. So the key takeaway here isn't necessarily that RTSA causes better function in PJI, but more likely that the patients who were actually eligible for an RTSA in stage 2 were already a different, perhaps healthier cohort with better underlying bone stock to begin with.
Exactly that. Their better starting point allowed for greater functional recovery potential. The patient's initial condition seems to be the major predictor of the functional gain you can achieve, particularly in those most compromised cases where options are limited.
That makes a lot of sense. It's about the patient factors as much as, or maybe even more than, the hardware choice in the end stage for these really complex cases.
It highlights the critical importance of patient selection, managing expectations realistically based on their initial condition, the state of their bone, particularly the glenoid, and their overall health.
Now, the paper also highlights complications. This is complex, high-risk surgery. We know that. What was the complication rate actually like in this series?
Well, unfortunately, and perhaps unsurprisingly given the nature of the problem, complications were common. They occurred in 58% of the patients in this study cohort.
58%, that's more than half.
It is. It really underscores the inherent difficulty and the significant morbidity associated with treating established shoulder PJI. This high rate also led to a substantial number of patients requiring further revision surgery down the line. 35% overall needed more operations.
Wow, 58% complication rate and 35% needing further revision. That's substantial. What were the most frequent complications that you observed?
The most common issues we documented included things like progressive glenoid destruction, bone loss on the socket side, occurring after the spacer was implanted but before reimplantation.
Right.
Also postoperative hematoma, subsequent shoulder instability after reimplantation, wound healing problems, which are always a concern, aseptic loosening of the eventual implant, meaning loosening not due to infection, and periprosthetic fractures around the implant or bone. The rates did vary slightly across the subgroups, but that overall figure of 58% is a clear reminder of the challenges involved here.
Definitely sobering figures. The study also, quite rightly, acknowledges its own limitations. What are the key points the authors mentioned there?
Yes, we were upfront about those. Firstly, it's a retrospective study, meaning we look back at data already collected rather than a prospective trial designed from the start. That has inherent limitations. As we've just discussed at length, we highlighted the significant baseline differences between the treatment subgroups RTSA, HA spacer data as a major limitation when trying to directly compare their functional outcomes. They weren't equivalent groups to start with.
The relatively small numbers in the HA and the spacer subgroups also limit the statistical power of those specific analyses. You have to be cautious interpreting results from small groups.
Sure.
And finally, there was some loss to follow up. About 21% of the original cohort couldn't be included in the final analysis for various reasons, which is quite common in long-term surgical studies, but still a limitation to acknowledge.
Understood. So, pulling all of this together now, the study confirms that this two-stage approach is highly effective for infection control, achieving that 95% rate. But functional recovery seems strongly linked to patient factors and whether they can actually proceed to an RTSA. What are the broader implications of this for orthopedic surgeons who are considering treatment options for shoulder PGI?
Well, I think it clearly validates the potential for a high success rate in terms of infection eradication using this demanding two-stage pathway, even in complex referral cases. That's a positive message. However, the discussion section in the paper thoughtfully brings up the comparison to single-stage exchange procedures.
Right, doing it all in one operation.
Yeah.
Exactly. Some studies investigating single-stage exchange, particularly perhaps for less virulent organism or different patient groups, report comparable infection control rates to the two-stage method. So, given the high complication rate we saw, the patient burden of multiple surgeries inherent in the two-stage method, especially if the specific pathogen isn't known right at the beginning, well, the single-stage approach becomes a very significant point of comparison and ongoing debate.
It really highlights that tension, doesn't it? Balancing the absolute priority of getting rid of the infection versus the goal of restoring function and minimizing the overall impact and risk to the patient.
That's precisely the crux of it. It's not just about clearing the infection anymore, although that remains critical. It's about finding the optimal path, the best strategy for achieving a functional outcome with the lowest acceptable risk profile for that specific individual patient.
It forces a really careful individualized assessment, doesn't it? Looking at the patient's overall health, the specific bug involved, the state of their bone, and what they can realistically tolerate and ultimately benefit from.
Exactly. There's no single one-size-fits-all answer in treating shoulder PJI.
Let's run through a quick lightning round then for some rapid-fire takeaways based directly on this research. Quickest win for infection control, according to this study.
The two-stage method itself. It yielded that 95% success rate for eradication.
Most common culprits identified in this particular cohort.
Coagulus-negative staphylococci and P. acnes were the top two.
Biggest predictor of functional improvement noted in this study.
It seemed to be the patient's underlying condition and their bone stock, specifically whether it allowed for an RTSA to be performed in the second stage.
A key diagnostic consideration highlighted for shoulder PJI, especially when you suspect P. acnes.
Extended culture times are crucial, at least 10 days incubation.
And one major challenge revealed starkly by the complication rates.
The significant inherent morbidity, the risk of complications, and the potential need for further surgery remain very high in treating these complex infections.
Excellent summary points. Okay, let's crystallize the core actionable takeaways from this deep dive for our listeners. What should they really remember from this?
Okay, Firstly, the study reinforces that two-stage revision using antibiotic spacers is a highly effective method for controlling shoulder PJI, achieving a 95% success rate in this particular series of complex cases.
Good. Takeaway number 2.
Secondly, restoring good shoulder function after treating PJI appears to be strongly linked to the patient's suitability for receiving a reverse total shoulder arthroplasty in the second stage. And that suitability is largely driven by their underlying condition and bone quality.
Right. And third,
Thirdly, baseline patient factors, particularly the extent of glenoid bone destruction, significantly influence both the treatment pathway that can be chosen and the ultimate potential for functional recovery. This is often more critical than the specific implant used in the most challenging salvage situations.
got it. Fourth takeaway.
Fourthly, accurate diagnosis of shoulder PJI requires diligent protocols. Especially important is using extended culture times of at least 10 days, particularly to detect those slow-growing organisms like P. acnes. Don't miss the bug.
Crucial point. Fifth,
Fifthly, be aware that this is complex surgery with a notable risk of complications. Nearly 60% in this series experience one, and there's a significant chance, around 35%, of needing further revision surgery down the track.
finally.
Finally, the study's discussion and our conversation today really prompts important consideration of alternative strategies, like single-stage revision. These might offer comparable infection control with potentially less patient burden in certain situations, highlighting the ongoing need to evaluate the optimal approach for different PJI scenarios in patients.
Professor Imam, thank you so much for guiding us through this research and providing such clear, really insightful analysis. Your expertise as an author on the paper has been absolutely invaluable.
It was my pleasure entirely. Glad to discuss it.
If you found this deep dive valuable, please do consider leaving a rating or perhaps sharing it with a colleague on LinkedIn or X. And to leave you with a final thought based on our discussion today. Given the high infection control rate but those variable functional outcomes and the significant complication risks associated with this two-stage approach, how should we, as an orthopedic community, best balance that aggressive infection eradication with the equally crucial goals of functional restoration and minimizing patient burden in these incredibly complex shoulder PJI cases? Something to mull over. That's all for this deep dive. Join us next time as we unpack another stack of sources.